Thank you for coming to this, the third HIV Prevention England conference. For those of you who don't know me, my name's Ian Green and I'm the Chief Executive of Terrence Higgins Trust. And Terrence Higgins Trust are delighted to be responsible for the National HIV Prevention Service, along with our partners, many of whom are in the room today. I'm pleased to say that over 350 people have been registered for this conference today, including colleagues from France and from Germany, and from all over the country. 150 different organisations and 30 speakers, presenters and chairs are all present. So thank you very much for giving up your time to be here. A couple of brief housekeeping announcements, if I may. No fire drill is planned, so if there's a fire drill, exit. The toilets are available on all of the floors, and the closest is near to the main hall to your left. There is Wi-Fi, and that's you find it in your conference pack. And so do feel free to use social media to tweet. The hashtag apparently is hashtag HPE27, and the HPE's new Twitter account is at HIV Prevention EN. So if you'd like to tweet or use social media, please do. Today's conference has three themes. Firstly, innovation in HIV testing and prevention. Secondly, community engagement, mobilisation and face-to-face interventions. And finally, partnership working, and how through that partnership work we can demonstrate collective leadership. An exciting day has been planned, and we're going to be looking at some key issues and challenges that are currently facing the HIV sector, focusing around HIV prevention. So we are, of course, going to touch on an overview of the changes in new diagnosis rates in London and across England, and the part which combination prevention plays on the HIV epidemic and incidence. We're also going to have an update on the impact of the PrEP impact trial, due to start in the summer of 2017. And some of us might feel that the summer of 2017 is already here, and where is PrEP? I can say that Deborah Gold from AIDS Trust and I had a meeting with NHS England and Public Health England yesterday, and so some further information is now going to be able to be announced, and Deborah will do that this afternoon. I think the thing to say is that progress is being made, but I think it's slow, very slow. So that will be an update later on. We're also going to be looking at the effect of rapid initiation of treatment on HIV transmission, that's treatment as prevention, and the importance of having an undetectable viral load and therefore being uninfectious. The launch of a new report by the National AIDS Trust on investment in HIV prevention and testing services in England, home sampling and self-testing in the UK, and using a partnership approach to provide sustainable HIV and sexual health services. And there's much more. And you'll see from your programme a range of different seminars and workshops that you can attend. And so do look carefully at the programme, decide which you want to participate in, and then fully engage. During the lunchtime, there's going to be a session by colleagues at Public Health England on the HIV Prevention Innovation Fund, and that's going to be giving some guidance about how to apply for funding through the Innovation Fund. That's going to happen in the George Fox Room. It will cover all aspects of the application process, including the scoring of potential projects and how the awarding process works. So if you are interested in applying for innovation funding, and a great opportunity for organisations who are wanting to innovate and to make sure that work is funded, then please do go along to that session. There's also a poster presentations exhibition along the East Corridor by the Gardens. This evening there's a drinks reception. I look forward to seeing you all there at the Wesley Hotel, not far from Euston Station, and that's kindly sponsored by our colleagues at Pesante. And the directions to the venue are on the back of the programme in the delegates pack. All the slide presentations are available on the HIV Prevention England website after the conference, and an email will be sent to you all with the link when the files are ready. These sessions in the hall are all being live streamed and available now, but also for anybody who's not able to be here today, but also will be available to view after the conference. And to watch the broadcast, visit www.hivpreventionengland.org.uk. That's all I want to say. Great to see you all here. And I will be chairing this morning's session and look forward to seeing many of you later on this afternoon. It's now my pleasure to introduce our first keynote speaker today, who does not need much introduction at all. Lord Fowler was Secretary of State for Health and Social Security in Margaret Thatcher's government and took a lead responsibility in responding to the initial HIV and AIDS epidemic and crisis. And since that time has been a passionate advocate for HIV and AIDS, both in Parliament but also in civil society and globally. He is a patron of the National AIDS Trust, of the Terrence Higgins Trust, and of the British HIV Association, and is currently Lord Speaker of the House of Lords. He told me earlier that because of the general election, he has 6 weeks off. And so it's great that he's able to join us today during his holiday. Ladies and gentlemen, Lord Fowler.
Well, thank you very much. And it's good to be here and see quite a number of old friends here as well. As you say, I've been elected now as Lord Speaker. My two immediate, I'm only the third, my two predecessors were both women, so at least I have broken through the glass ceiling of female domination in the House of Lords. Everyone says to me, just as you have just said, you must be very busy just now because of the election. Well, as that character in Evelyn Waugh's Scoop says to his proprietor, up to a point, Lord Copper, because the fact is I don't have a vote, and as a Speaker, I'm banned from taking any part in party politics. So what I'm doing instead is I am putting into order some of my notes and papers going back years, from my period as a minister back in the 1980s. And as it happens, I have just reached 1986-87, and my notes on one of the most profound public health challenges that the world has ever faced, and that, of course, is the challenge of AIDS. Looking at the position today, you are obviously struck by the enormous change, the revolution that has taken place. No longer is it the position where doctors and nurses had to stand by impotently as their patients died before them, and there was absolutely nothing that they could do. No longer is it the case, in Britain at any rate, that acquiring HIV is an almost certain death sentence. And no longer is it the case that the most powerful nation in the world looked at the figures, but said, and the American Health Secretary told me, that it was not a national issue, it was a matter for local decision in the United States. That was then. But the 1980s was not only a period of personal anguish, it was also a period of damaging and discriminatory analysis. You had people who quite seriously put forward a proposal that people with HIV should be segregated and live away from the general population, even though we even knew in those days that HIV was not transmitted like a common cold or by sharing a cup. You had a figure of authority like the Chief Constable of Manchester in December 1986, accusing those with AIDS of, quote, swirling in a cesspit of their own making. You even had the chief rabbi objecting to our advertising campaign on the grounds that, I quote, it tells people not what is right, but how to do wrong and get away with it. It's like sending people into contaminated atmosphere, but providing them with gas masks and protective clothing, or instructing thieves how to escape being caught. It's not surprising, therefore, when figures of authority of that kind uttered such statements, others followed behind. Today, 30 years later, much has changed. Antiretroviral drugs has transformed treatment in Britain. The government has legislated for equal marriage. We all know that there are other steps, many other steps to be taken, which I come to, but the position is so very different. But before we even begin to relax into a feeling of some complacency, we should remember that in great parts of the world, it is still the 1980s. They cannot indulge in looking back and condemning the lack of action then. Their problem is today and now. We still have many, many countries where people with HIV are denied treatment. We still have many, many countries where hundreds of thousands of men and women with HIV are undiagnosed. And we still have a position where people with HIV, gay people, drug users, minorities like transgender people suffer discrimination and persecution. And let us just remember around the world that there are over 1 million deaths a year from AIDS. There are over 35 million people around the world who live with HIV and something like 13 or 14 million who are undiagnosed, presenting them a danger to themselves, but also obviously a possible danger to others. It is a vast public health scandal. And as we should also remember, there are 73 countries where homosexuality is illegal and people can be prosecuted, imprisoned, and worse. According to Stonewall, approximately 40% of the world's population live in countries where gay, lesbian, and bisexual people can be imprisoned. If you take sub-Saharan Africa, you have countries like Uganda where people are, as I saw when I went there, people are literally persecuted and persecuted openly for being gay. If you take Russia, again, which I visited, you find discrimination not just against gay people, but drug users as well, who are regarded as virtually the lowest of the low. And even if you take a country like India, you find discrimination against women and transgender people. And so you may ask, well, what has this got to do with us? And some, of course, will say nothing. We should simply look after our own people, a popular cry. Well, over 100,000 of our own people are today living with HIV, and we are adding to that number by 6,000 a year. So there is a challenge alone in those figures, because all problems do not simply melt away by the use of one pill a day. Things are not perfect here, anything but. But we do, I would suggest, have an experience and a skill which can be shared and also should be shared with other countries. My hope had always been, when I was doing the health job, had always been that this country should show leadership, should be some kind of model which people could look to in the world. By that, I do not mean that we should go out and lecture. There's an instructive story about the speaker of Uganda who went to an international conference on HIV and was roundly lectured by everyone in sight. She responded strongly, not remotely accepting the criticism. Her reward was a ticker-tape reception when she returned to Kampala. It's much more hopeful to work in partnership with national organizations who share the same aims. Voluntary organizations here give the proper support, given proper support, could play, I think, a very important role indeed. We might start by explaining how things have changed in Britain. Some attitudes have changed. I remember being in Delhi when a politician there blamed the British for the discrimination and other hostile attitude to gay people. Now, as a historical statement, that obviously has much force. We were, after all, a country who only 60 years ago put Alan Turing on trial for homosexuality, and we can all think of many other examples of cases of that kind. But the point really is that in spite of that history, we now have a law enabling equal marriage, which would have been unthinkable only 10 or 20 years ago. Many attitudes have changed. The percentage majority for reform of the law in Parliament was actually bigger in the House of Lords than it was in the Commons. I need to put that in as justification for my House. So does that mean that we have solved all our problems? And just as certainly, obviously, it does not. If in anything we say here in London, we should also be frank that there are still issues here to be settled and to be solved. There seems to me a fundamental question first. Do we really even now attach the importance we should do to public health? I remember when we were introducing clean needles for drug users, we had particular opposition, and particular opposition in Scotland, which ironically had the very worst problem. And the argument was that if we were to give out clean needles, we would be condoning crime. That's what the Edinburgh police said, and that is what the Edinburgh press said in unison. The Scottish Health Department set up an expert committee, and their finding has, I think, a relevance even to this day. They said the prevention of the spread should take priority. In the end, of course, we did produce clean needle exchanges with fairly dramatic results. The route of HIV caused by sharing dirty needles has been effectively closed now for many years really, and the policy has been followed by a range of countries around the world. And incidentally, there is absolutely no evidence of drugs crime increasing as a result. Today, we face obviously different issues, but leading to the same question. How much priority do we place on public health, given that the policy may well be attacked by some? If I may say so, I think PrEP is a prime example. There's no sensible argument against the introduction of PrEP if your aim is to prevent the spread of HIV. It would be an undoubted aid to public health. You don't need, frankly, another trial to establish that. Nor should we be deterred by arguments that this is simply enabling, quote, promiscuous behaviour. As the Scottish Committee said on clean needles, the prevention of the spread should be the priority. And let me say, as an outsider, I never expected to see a voluntary body being forced to go to court to argue that the health service had the power to provide such drugs. Even more, I never expected the argument to be put forward that treatment should be withheld because there were more desirable conditions for money to be spent upon. We're really taken back there to the early days of the outbreak, good illness and bad illness. We all know that conditions like HIV are not automatically popular. We all know that. We all know that it is the same with other sexual diseases. There are issues of shame that prevent people coming forward for testing and for treatment. That is why we have had a long tradition in this country of confidential treatment. And if I may suggest, it's all the more reason why we should be very cautious about the arguments we employ and the language that we use. And then we come to stigma and discrimination. Last month, the King's Fund published a very important report, which I strongly advocate anyone who hasn't read it to look at. That report basically found that stigma continues to be a major issue in this country 36 years into the epidemic, affecting the psychological and emotional well-being of people living with HIV. In a national surveys of people living with HIV, around half of respondents reported feelings of self-stigma. Even worse is the evidence that experience of stigma is often in healthcare settings. 1 in 8 in the stigma survey avoided seeking clinical care because of an expectation of being treated differently. The focus groups used to guide the report said that many of the participants could, and I quote, readily give examples, many of which were shocking and frequently incurred in healthcare settings. They included examples of people being prepared to disclose their HIV status without being able to control how the information was communicated. I just give one example, which to me, at any rate, came out from that report very firmly. And it was in a health setting. And the lady concerned said, when they found out that I'm HIV, the other lady who was looking after her, meant to be, came to me and looked at me and said, "Oh, are you HIV?" And I said, "Yes." And she said, "No, I don't believe it." I said, "Why?" "Because of the way you look and because of the powder, the makeup which I'd put on." And she says, "Yes, I look on you as, and you're not HIV." I said, "I am HIV positive." So she went, told her other colleagues, and they came, 4 of them, and they looked at me. Well, that is actually happening in Britain today, and it's a pretty terrifying story. So it takes us, I think, right back to the beginning of the last century, when a royal commission recognized explicitly the need for confidentiality and for understanding when confronted with sexual disease. So, just in summing up this short introduction, I would just say this. There's no conceivable doubt that we have made enormous progress and dramatic progress. Treatment inside clinics has been transformed. We now have the advantage of drugs which in the 1980s we could only dream about. The specialist consultants, the doctors, the nurses who have helped to prevent death, which was all too often the outcome in the past, and voluntary organisations like your own Terrence Higgins Trust, like National AIDS Trust. They are the heroes of this transformation. But as the King's Fund says, there is still a distance to go. Yet, the other side of the coin is, compared with so many other countries around the world, the progress has been formidable. So, my view is that we, as well as looking after our own position, should also share that experience, not to instruct or bully people, but to say, this is how we are doing it here. We don't pretend to have all the answers, but we do perhaps have some, and if we can help, we would be pleased to do so. That seems to me to be a constructive way forward in an era when AIDS and HIV is anything but yesterday's problem. Thank you very much.
Lord Fowler, thank you very much for that really insightful opening to our conference today. And can I, on behalf of all of us, thank you, Norman, for your passionate advocacy for HIV and AIDS in Parliament and in wider civil society. We could not ask for a better champion, so thank you very much. It's now my pleasure to introduce Professor Valery Pche from Public Health England. Valery is going to speak for about 30 minutes, and there's going to be about 10 minutes for questions. Valery, I need to say this very clearly, what Valery is presenting today has been presented before. That's to get over PERDA rules. So nothing is new. The information that's been presented today was presented at the recent British HIV Association conference. But it's good to be reminded of it today. Valery is a public health doctor who leads a team of epidemiologists and data managers at Public Health England. And they are tasked with monitoring the HIV epidemic and the quality of HIV care delivered through the NHS in the United Kingdom. And this information and knowledge is critical to planning and tracking our efforts to prevent HIV and other sexually transmitted infections. Ladies and gentlemen, Valery Pche.
Thank you very, very much. And thank you, Ian and Kerry, for the invitation to speak today. And thank you also to Lord Fowler for setting the scene and inadvertently also bringing up all my home messages, take-home messages, speaking. So I'm going to go back just a little bit. Yes, there we go. Today I wanted to really set the scene for what is really now a very, very exciting time. For the first time, we really can be proud of the efforts that we've all been putting into eliminating HIV. Now, this word elimination is obviously probably an impossibility. We'll never get to 0-0, maybe we will, but really it's a term that we use particularly to say that we get to a stage where the onward transmission becomes so very low that it's very, very manageable. And WHO have a definition of transmission of less than 1 per 1,000. So that is a definition. We are actually quite a low overall in general terms. Transmission in the general population in this country is already way below that, but we know that we have specific populations that are above that. So we've had some exciting results in the last few months, and as Ian rightly said, these have been presented, are in the public domain, otherwise I'm in big trouble today. So what are the take-home messages? Combination prevention is working. Now we know it should be working, and for many years I've been presenting models to show what could happen if we did X or Y or Z. Now we actually have real live data to show that that is happening. And we've been seeing this in the downturn in new diagnoses, particularly among gay men and bisexual men, and other men who have sex with men, and I'll use the term a bit interchangeably. What's really clear is that what's working in specific parts of the country need to be replicated, and we need to continue our efforts. That means not just testing, it means rolling out PrEP, it means continuing our condom prevention efforts. It also means earlier uptake and delivery of antiretrovirals to those who are diagnosed positive. So it's very, very exciting times. It's also, and I would echo again Lord Fowler's comments, we are in a very privileged position in the UK to be able to really monitor these observed effects in probably more detail than most countries. And these are very, very important lessons learned. What's working? We can go down to very local or regional level around our efforts and better understand what needs to be tweaked. And those data are going to inform not only the response within the UK, but are critical at an international level as well. So the facts for 2015, you probably know these are data out, but the top line figures, we still have 1 in 6 people unaware, but undiagnosed infections have been coming down a little bit, particularly among gay men over the last few years. And until last year, we had 6,000 people newly diagnosed. Now, what is going to be 2016 is currently being analysed in Public Health England and will be released in the next couple of months as the data comes in. And we have a continued number of people living with HIV who die each year. Sadly, the majority is still dying of AIDS-defining illnesses because they're presenting late. So I presented these data, and these were models that Andrew Phillips used, using the baseline data from public health to postulate what could happen if we improved our testing patterns. And I'll show you if we had, for instance, the possibility, the current very light blue line was the testing at the time that the data were pulled together in 2012, and basically showing less than half of gay men were getting tested within a year of their infection. And if we were able to increase that to at least 60% or even 90%, that could improve substantially by narrowing the time to infection and diagnosis So going back to that line, if we're also including in the red treatment immediately rather than just at ART at 350, this could improve. And really what's striking is that this is exactly what's been happening. And we have, as well as that, because at the time PrEP wasn't considered, the value of PrEP. So we are actually seeing what the models were showing. And you can see with better uptake of early treatment and getting people tested much earlier, we can reduce transmission quite considerably, and that's what we're actually seeing. So in the UK, an overall slide that many of you know. I guess I wanted to point out that we are still in a position where HIV continues to be stigmatized and affecting mostly marginalized communities in some ways. The epidemic is diversifying quite a lot. About 20% of men who have sex with men each year now are born abroad that are diagnosed, for instance. And we're seeing a lot more HIV acquisition within African communities within the UK than we have before. And also care is becoming quite complex with multiple health conditions. So even though 1 pill a day is definitely improving life expectancy, and in fact, life expectancy, which a Lancet article only last week noted that life expectancy now is as normal as the general population, provided people are diagnosed early, is fantastic. However, there are still some barriers, particularly around testing and stigma, and also access to testing is one of the issues that has been bugging us in this epidemic to reduce transmission. When we look at people living with diagnosed HIV across the country, the large majority are men who have sex with men of white ethnicity, followed by heterosexual of Black African ethnicity. But you can see also quite a diverse range of other groups. I just wanted to put that to show the diversity. And also, we've been looking at complex care. And this slide, which is presented Beaver again, shows that actually up to 13% of people, based on a definition of what the HARS data collect, are complex, have complex needs, and therefore their care is not a straightforward necessarily just attending the clinic once a year. So there are some issues there in terms of service delivery. Okay, I want to come back to the context of what's been happening and really talk about some of the key developments in recent times. As you know, the NICE guidelines came out last year. We've had some good guidelines, and we've had a revision of guidelines and new guidelines coming out, which again stress the need for testing in a variety of settings to ensure that people presenting later are diagnosed much earlier. But also we've had some new testing modalities, and this conference certainly is going to bring that out. We've got some sessions presenting the home sampling and the home testing results. And we've had obviously also the introduction of the PROUD trial and a lot of internet access to PrEP. And Prepster and the gang are here, so thank you for coming. So it's been really, really important developments just in the last few years. And we know that these modalities are profoundly changing how men and women are accessing testing. And that's also making an impact. At Public Health England, we primarily are monitoring activities that are occurring through the NHS, and we're trying to supplement our information that's happening through community. But that means some of our bias in the data we present are very much what we can collect, and I'm very keen for us, and certainly our HIV testing report that Nikki Connor at Public Health England produced with the team last year really tries to pull together all the testing of HIV throughout the country in various settings, and we need to get better at pulling that information from the community. Equally, we're not very good at the moment at tracking PrEP, and we need to do that better. And while we can debate around the words for trial or study or for PrEP, one thing I'm extremely keen on is that we actually monitor the uptake of PrEP so we know how well and how effective it is and what impact it's having on gay men. and other people who of high risk who take PrEP. So new diagnosis data, as you know, have actually been declining among heterosexuals for some time, although we have actually put that down to a reduction of new diagnoses among people born abroad who were migrating to this country and probably infected abroad. And therefore, this wasn't really a success story of prevention efforts in this country. And what we've been showing all along, although last year we did see that small drop in 2015 and we're not quite sure, is that we are seeing a drop in gay and bisexual men. Here it's just to show the diversity again of the epidemic among newly diagnosed. Just over half are born in the UK and the other half are from various parts of the world. And certainly what we're seeing is the number of, among heterosexual new diagnoses acquired abroad has been dropping, as I've said, with really a steady number of UK acquired infections among the UK born and acquired abroad over time. The epidemic is diverse also among heterosexuals, and you can see now, as we've had quite a big downturn in new diagnoses among Black African men and women, the ones among white heterosexuals are actually catching up. So we're in a situation now that we have about equal numbers of heterosexuals who are diagnosed from white and other ethnicities. What's been also striking over time is that we have seen a downturn in the number of people who have presented at late stage. So these are actual numbers rather than proportions, and sometimes it's really important to see both data. And you can see how overall we've gone from almost over 4,000 in 2006 down to 2,500 people presenting at a late stage, still defined here as a CD4 less than 350. And most of that has been actually in gay and bisexual men, but also in other groups. And if we can look at new diagnoses among heterosexuals here, split up on whether they were diagnosed promptly, you can see actually the late diagnosis has reduced significantly among heterosexuals. And those diagnosed promptly have slowly come down as well. And this is the theory around most of those infections are due to not people being infected necessarily in the UK, but abroad, and being better at also catching up with diagnosing people a little bit more promptly. And as a result, what we do is look at the 1-year mortality rate, because we know the 3/4 of people who are diagnosed with HIV, who are going to die of HIV at a younger, premature age, usually it happens within that first year because of late diagnosis. And you can see the big difference of when people are diagnosed promptly, the blue line, the mortality rate is much higher, 1-year mortality rate compared to those, late compared to prompt. You can see the difference here. And there is a tendency here of actually a drop in also the mortality rate in those diagnosed promptly, because we are starting treatment much earlier as well over time. For gay men, it's quite a different striking picture, and I wanted to focus on that because it actually touches on the slides that I'm going to talk about in terms of the reduction in new diagnoses overall for gay men. And what you can see here is we've actually not tapped very much. So there's been a small drop in people diagnosed, in men diagnosed late, but we're still hovering around a 900 to 1,000 diagnosed late. It'll be very interesting to see the data for 2016. And here it's 2014 because I'm using that for the next slide. But you can see we've been much better at getting men to get diagnosed earlier. And so we're picking them much more promptly, and we've had a rise in the median CD4 count over the last decade, year on year. And that is largely due to people testing much earlier. And so again, the mortality rate here is much lower among those who are diagnosed promptly. So diagnoses through our STI services are For gay bisexual men, the sites where they are mostly diagnosed, they account for over 80% of all men diagnosed. So when we compare the GumCAD data with the HARS data, you can see that they practically mirror each other. But we are starting to see more men being diagnosed outside the STI clinic. So today, when I focus on our downturn in new diagnoses in STI clinic, I'm ignoring what's happening outside. We'll have to reconcile that when we get all of the HARS data for 2016, but just to be aware. However, they mirror each other quite closely. And when we look at new diagnoses specifically in sexual health clinics over the last 4 years, right up to Q3, and Q4 will be released just after the election, I think, or even earlier. And I think, although I haven't said this, we will continue to see a downturn in new diagnoses among gay men. So you can see here what's striking is that there's been very few heterosexual men and women really diagnosed compared to gay men, but there's been a substantive downturn in new diagnoses, which is very real. We've looked at this quite a lot. This is not reporting delays anymore. This is factual. We're seeing quite a downturn. And what we did is looked at the data by stratifying it according to different clinics, and we used an arbitrary definition to try and study the clinics that showed the biggest downturn, using a definition of at least a 20% drop between last year and this year, up to Q3 2016, in clinics that had at least 40 diagnoses in that period. Otherwise, it's very, very small, and you can easily get a 20% drop if you go from 10 to 7 diagnoses. And the 5 clinics that showed that very large drop were Dean Street, Mortimer Market, Homerton, St Mary's, and Guy and St Thomas's. So those clinics are going to be for a few slides when I talk about the large 4 clinics. That's the clinics I'm talking about. And then we've compared that to the London clinics, other London clinics, and then clinics from the other parts of England. And the data here in red shows how, obviously, because we've defined them, shows the steep fall in those clinics compared to the other parts. But you can see also we have had a small downturn in clinics outside London, although they didn't fit that definition. And we're going to be looking at the data much more closely, not just in those 3 strata. In fact, one thing that is proposed is the data is so rich and helpful that we want to try and produce this at defined geographical areas that really can inform further testing and also uptake of treatment, which I'll go into. So testing, innovation, and we've got a lot on this conference, some really, really exciting results and testing initiatives, and there's been a lot of community testing and innovation going on. And although it's not captured all in the data, I think it is one of the profound developments that we've had in HIV testing. Self-sampling and self-testing are some examples, but also using innovative ways of reaching people through social media, expanding testing in emergency departments, and the use of pocket tests in particular to make that happen. So a lot of exciting developments, and some of these are obviously in our program today. We've also had Testing Week. This is the European Testing Week site, and we have a similar Testing Week in the UK to galvanise and really promote testing, not just for that week, but to increase activities. And that's also shown in our GumCAD data and other community data, certainly a spike in testing over that period. And now we're trying to couple those testing with other initiatives, including hepatitis C in relevant communities, for instance. So testing in gay men in STI clinics, looking at those data, we also split the data in testing according to whether men were recently, had already tested at that clinic in the last 2 years or not, as repeat testers, just to see the different patterns. And you can see repeat testers has gone very, very much higher than new testers, which has hovered around 4,000 and 5,000. Also, there's been increases. And this is in the London 4 clinics, the big 4 clinics. And testing has gone up phenomenally from around 4,000 to now 10,000 tests being conducted in gay men in a quarter. I do have to single out Dean Street as being phenomenal for these efforts. Probably 40% of the data here is the efforts of Dean Street alone. So something has been working here and it's been phenomenal. And when we look at the frequency of testing for those 4 clinics, you can see as a proportion going from 2012 in blue through to the 2016 data in green, that the number of people testing more frequently, all men of course, is going up, so that we now have a large number of men who are testing at least 4 times a year in those clinics compared to 2012. And that's the pattern we want. If we go back to that model of Andrew Phillips, we're wanting men to test much more frequently, and at least 90% of all men who could have been infected in a given year are tested, and this is the only way to reach that. So going back to that slide where we're showing the testing and now superimposed new diagnoses by new testers as well as repeat testers, you can see that there's been, the blue bars, a real downturn in new diagnoses among people who had presented to the clinic for the first time in the last 2 years. There is a downturn in the new diagnoses in the red bars for repeat testers, but it's not as profound. And this is really a very interesting way of looking at the data. We've repeated that for the last year and it looks very similar as well. But really what's showing is that the repeat testing is actually having an impact on new diagnoses among the new testers as well. Of course, it's not just the testing. I'm going to go into the uptake of treatment as well. And of course, we've had PrEP and we've got other initiatives, prevention initiatives there. Very different picture if we look at the rest of the London clinics. We've used the same scale here just to show, compared to 5 to 30 clinics, the number of tests and the number of new diagnoses, pretty much flat, business as usual. Not to say they're not doing a good job, but it's a very different picture. Outside London, you can see it's much larger, but you are talking about 190 sites. So it's a lot more sites that are included. And although the testing has been going up, one could say that given the scale and the large geographical area, testing is really still not effective enough to have profound effects on reducing new diagnoses. Treatment as prevention. Now, one of the big things about treatment as prevention, and globally, I just wanted to remind everybody, is that we've had a big shift with WHO calling for treatment for all for some years now. In this country, we are just still reviewing whether or not everybody can have treatment, although everybody can have treatment as prevention. The initiation, irrespective of CD4 count, is quite vital to ensuring that people can not only look after their health, but reduce their onward transmission. And certainly this graph pulls together, and this is coming back to Lord Fowler's point about the UK being in a very privileged situation compared to many others. We're right in that corner up there, one of the highest countries where when people are diagnosed, they're very likely to be on treatment overall. And you can see many countries fall way below the line, and that situation is really critical to transmission. And the continuum of care, as you all know, is excellent once you are in care. However, we have improved to ensure that people living diagnosed are put on treatment as early as possible. And you can see last year, more people started treatment than any other year, even though the new diagnosis rate was the same. And that's because in the purple there, more people with a CD4 count above 500 are starting treatment. And that is very good news for treatment as prevention and individual health. And what we can see, and here we've split up into those 3 clinic categories again, we've had a decline in the median time to from diagnosis to treatment, and as soon as you're on treatment, within a few weeks, your viral suppression also occurs. However, we can still do better. 100 days is still 100 days. Certainly, I think Dean Street have introduced also a pilot, which I'm not sure if you're talking about, but was presented, yeah, you're talking about it here, which really showed how we can effectively get people on treatment very, very soon, even within a few days, and how much of an impact that then can have on the epidemic because you're reducing infectivity time. And overall, we did a transmissibility equation, if you like, where we actually, for those areas and clinics, we added the number of people we knew not on treatment with those who are not virally suppressed, and added the estimated number of undiagnosed, and just to show in the steep fall clinics in those geographical areas a very sharp downturn in the number of individual men, if you like, who would be potentially infectious. And this is sort of a marker of infectivity, community infectivity, and that's been declining right across, and that's because we've been reducing the undiagnosed fraction, but also putting people on treatment much earlier. And that has to have also a profound effect on reducing transmission. And if we think of that as a transmissibility ratio, which is sort of the next bit, where we put that same number of men with transmissible virus over the number of high-risk men who are negative and had an STI as a proxy for high risk, we can see in those steep fall clinics that that ratio is way below 1. In other words, very low, much lower risk of transmission in that context than in other clinics. This is a simplified way of saying community viral load remains very high for the total number of potentially men susceptible to infection. So what's next? Well, the 2016 data are being analysed and coming out. We need to make sure our incidence estimates are also, because I've been talking about new diagnoses, how do they translate to actual incidence? I am sure they're going to translate to a reduction in incidence among gay and bisexual men. However, we can still expand to earlier testing and really take on the lessons from those steep fall clinics to see what can be done in other clinics across the country. We must make availability, yeah, is that spelled right? The availability and monitoring of PrEP as an absolute paramount, and that's all I can say today. And we need to make sure that we engage and include all people most at risk of acquiring HIV in those discussions and those programs. So just to remind you, incidence is in itself, maybe we've said it's been plateau, so it hasn't increased over time. We're hoping that will come down for gay men. And also we need to diversify, and I just wanted to mention our gender identity new field in HARS, which we'll talk about with Michelle a little bit later on, just to say that we need to make sure that we're monitoring, so we need to monitor things a little bit more effectively at Public Health England, and one of the key areas that we're going to be focusing on is ensuring that we monitor gender identity properly, because this is something that's not been done, and if we do it well through the HARS data set, it will be a model for the rest of the NHS. You've seen my summary before. It is exciting times. I think we have extraordinary opportunity to capitalise and really see a downturn in new diagnoses in gay men, but also use exactly the same knowledge and understanding for other groups most at risk of HIV, and ensure that those data and the lessons learned can gain further gains for reducing the epidemic in this country, but also internationally. Thank you very, very much.
Thank you very much, Valery, for the richness of that data and for presenting that in such a clear and understandable way. There is the opportunity for 5 minutes or so of questions. My colleague Ben is the roving mic, and he's there. So any questions for Valery? We'll take 2 or 3 at a time, maybe. That's a hint for people to put their hand up. Who's going to be first? Yep. You need to run, Ben.
Thank you very much, Catherine.
I think so.
We've actually, I couldn't present it today, but we started looking at this very issue. The level of testing in STI clinics among Black Africans is very, very low. So gay men, we're looking at now around 100,000 tests being conducted across the UK among gay men, and that figure is more like 10,000 for Black Africans, even though the population sizes are probably comparable to some degree. So we can do a lot more. Now, obviously, we've been talking about, you know, expanding testing, and the NICE guidelines talk about expanding testing in other areas. I still think there's a lot of room for ensuring that we can provide more accepting ways of getting African communities to test in much larger scale if we're going to reach the same downturn as we're seeing. So it is work we're starting to do. Interestingly, where the positivity rate among Black Africans when tested is exceedingly high in GUM clinics. So thank you for the question, and that's certainly on our work plan, and we'd like to present these data. I mean, this has profoundly changed how we're going to probably do our annual report. And if you're interested in being involved in the production of the annual report, please get in touch. I would love to have a committee to look at that. How do we want to present the data now, and particularly more localized data, because the information was profound in the London drop clinics, because we had clinics telling us what's going on. We need to hear it. So I would love to do that work so that it has meaning at a local geographical area.
Question there.
Thank you, Valerie. Anna Tolman, Anya Hansen, guys in St. Thomas's. I'm really interested in partner notification and the Pche data. When you look at PNH codes and then the positivity rates, we only find a 5% positivity rate, but it's still very high. In audits, it's 20 to 25% of partners test positive. You haven't talked about partner notification here. I was just wondering, what are your thoughts on that, and what we can do to improve the disconnect between those audit data and the PNH data that's coming through?
Yeah, I think partner notification is absolutely essential to the whole prevention and linking to care. And I think we haven't been good at really capture. It is very hard to capture, as you know, partner notification, and people come and get lost, and they go from one, as in the information gets lost from transferring from a STI clinic to a HIV clinic, and we haven't got it as well as we could, and we've been looking at that data. I think the GumCAD data has improved a lot in capturing that information, and we know that wherever a partner, you know, is tested, the positivity rates are extremely high, so it's very, very effective. I'd love to talk to you more about how we could improve that even further, and it's something I can take back to the GumCAD team as well.
Any other questions? Yes, gentleman here.
Hi, there's Steve Worrell from Positive East. I'm just wondering about community testing, though. All your data is very much based in obviously in GU clinics where it's easier to track. But a lot of testing takes place in the community. People get their initial reactive tests in the community. I'm not too sure where that data actually goes or how it captures, or actually the impact of that in terms of the data that you're showing there.
Absolutely right. We're not good at capturing community testing or community prep at the moment, and there are two big areas that we need to look at. Nikki Connor from Public Health England, who coordinated our HIV testing report and is actually looking at the EC2 specifically, is here. So I'm going to pass on.
Nikki.
Just say we're aware of that. So, is this working?
Yes, it's on.
Last year we produced the first Pche HIV testing report, and we were aware that we didn't have community testing data other than the home sampling service and the testing data that BioSure gave us. So what we are trying and working on right now, is with the National AIDS Trust and HPE to see if we can get some community testing data and getting the very first developments of can we do a survey to capture this, because we're aware that it's a missing part, so we're working on it.
Just one last question there from Philippa. Just behind.
Philippa Matthews, GP from the Royal College of GPs. The potential for testing in primary care is huge, and we've done an intervention in Haringey that's led to 600% increases in GP HIV testing with positivity at 1.4%, which seems very high. It isn't point-of-care testing, it's normal venous sampling along with other tests that GPs choose to do. And I'll be presenting the detail of that later, but it would be really good to see Public Health England looking at the potential of that. I think that particularly people from other countries and from high-risk communities outside the men of sex with men who are using postal testing and self-testing at scale is not looked at enough. I think that there's plenty of evidence we can do better in primary care, and I would say that in some areas we already are.
Vicky?
Just to add to your point and to the point you made before about partner notifications, we're also from Public Health England working with NICE to develop quality standards, and these are going to include both of these elements, so really trying to normalise HIV testing in lots of different healthcare settings and improve partner notification.
Well, thank you very much for those questions, and can I ask you once again to thank Valery Pche for her contribution. So I have a bit of a hunch. My hunch is that if clinicians, commissioners, Department of Health, NHS England, Public Health England, community and voluntary organisations and activists all work together collectively, we could have a massive impact upon the epidemic in England. I really believe that. And my colleagues at Terrence Higgins Trust will know that I bang on quite a bit about a term called generous leadership, about how collectively we might lead differently in order to have the most effective impact upon our beneficiaries and our service users. And I wonder whether that's a model that, as a sector, we might want to explore as well. And I've had the privilege over the course of the last 6 months or so to have joined a group that has been inspired by Dawn Alswick, the Chief Executive of the Big Lottery Fund, to explore the concepts around generous leaderships and impacting upon society and community. And so Dawn was, I was delighted that Dawn was prepared to accept the invitation to contribute today. Before she joined the Big Lottery Fund as Chief Executive, Dawn was the Chief Executive of the Esme Fairbairn Foundation and has held a number of senior positions, mainly in the voluntary and community sector. And so I'm delighted that she's here. And Dawn, I'm very pleased for you to give us your contribution.
Well, thank you very much, Ian, and thank you very much for inviting me to be here. I kind of think he's done it all, actually. He's said it, so I'll just be a little bit of icing on the top. I also am conscious that I stand between you guys and coffee. So we're going to canter because you're probably raring for a cup of coffee and a gossip and some networking. But I am going to talk about generous leadership. I'm going to start from the Big Lottery Fund. It's great to be here. We've got a long-standing relationship with Terrence Higgins Trust and with many other HIV prevention charities. And it's great to see so many of you here today. For those of you that you don't know us, we're the largest distributor of good causes funding that is raised by the National Lottery. So when you go and buy a lotto ticket or a Euro Millions ticket, you are helping to support communities across the whole of the UK. So thank you for doing that. Keep on doing it. And the money does flow from communities and back into communities. That's kind of the point of it. About 90% of our grants are for less than £10,000 a year. So we really do operate at quite a grassroots level. And we make about 12,000 grants a year, and our budget is typically about £600 million a year. So it's a lot of money for the voluntary sector. It's a tiny amount of money when one looks at the entire statutory sector. And as I say, we've supported a number of organisations in your field. We're not experts, we're generalists. I'm a particular fan of Body and Soul. We've actually used their spaces frequently. Love the top floor, love the lunches. If they're here, they're great. But we've also been a grant funder of them, particularly for their programme Strengthening Foundations, which works with children, teenagers, adults and families who are affected by HIV. Very different, the NAS project, Close the Gap. That was a project actually about photographic workshops for women living with HIV. And they used that process to explore and share their experiences. Or the Peel Institute and their HIV wellbeing programme. Peel Institute's in Westminster, for those of you who don't know them. So we have a sort of range of relationships into the sector. And I think that one of the things that has come through to me very clearly, both in preparing for this, but also in listening to the excellent speeches so far, is that actually, and I think this is why Ian probably asked me to speak, that HIV prevention succeeds through taking a holistic approach. There are so many different elements, from issues around stigma, which is often about fear, about the complexity of what goes on inside a human mind and a human heart, through to sexual health education, lots around testing clearly, public health, etc. And that actually, in order for all of that to come together, people have to work together. And what's interesting, I think, is you are a sector that in some ways has a very clear and unifying goal, which ultimately, even if you're interested in a particular part of the population, a particular group, you all actually have that overarching mission to prevent HIV. So I guess generous leadership is all about how can we work together more effectively to have more impact. And if I can then link that into our own strategy and way of thinking at the Big Lottery Fund, we describe our strategic framework as being about putting people in the lead. And I use two bylines to explain that. The first is that as a funder, we should be asking people not what is the matter with you, which is typically what funders do, and it's kind of default, but actually what matters to you. What is it that you want to achieve, and how can we help you do that? Not what's wrong with you, and how can we help make you better or improve. So it's very much starting from that strength-based model rather than the deficit one. The other expression I use, which I've seen used in various places actually, and I think its most common currency recently has been in the disability movement. Nothing about us, without us, is for us. This is about whose table are we sitting at. And we're sitting at the table of the people that would like money from us, in our case. And therefore we have to understand what they want, that it is their table and that they should be making the choices and the decisions, and that we should be helping them to do that. In a generous leadership context, that's about us understanding what is our place in this complex universe and how can we most add value into that. Just to sort of bring it back to the sort of realities of what we do, we've got 3 strategic aims in our England portfolio. We support ideas that bring people together, that strengthen their relationships both within communities and across communities. We want to support people to shape and sustain the places that matter to them, whether that's a park or an online network or a community centre. And we support activity that empowers people to fulfil their potential, working to address problems at the earliest possible stage. And I think underpinning all of that and the way in which we want to realise people in the lead is a recognition that context matters. It's all about the ecology, in effect. And that ecology is often very complex, involves many different players. And if we think about the context of the voluntary sector. I'm not going to attempt to analyse your own sector because you know it much better than me, and I'm really not in any way even a generalist expert on HIV prevention. But if you look at the voluntary sector more widely, there's 160,000 charities in England and Wales. 80% of them have an income of under £100,000 a year. 50% of them have an income of less than £10,000 a year. By the way, those are the people that get those £10,000 and less under grants of hours. That 80% account for less than 5% of the income of the charitable sector. If you go to the other end of the spectrum, 3% of charities have an income of more than £1 million a year, and that represents 80% of the sector's income. So this is not a homogenous sector. It's diverse and it's heterogeneous. And that's before you've even thought about all those voluntary groups, those associational organisations that are too small to register as charities. There's a very old piece of data from the early 2000s that suggests that might be upwards of 500,000 organisations. I suspect these are some of the communities and groups that you guys might want to be working with. Some of you may even be some of those groups. And then, of course, at the other end of the spectrum, there's lots of social businesses in this country. So the sector of doing good is quite a complex one. And it's a changing one. So it's not just diverse, it's also dynamic. If we think about what's happening to the charitable sector and so on, smaller charities, if you look at the NCVO Almanac, tend to be earning less money and eating into their reserves. Alongside the reduction in the overall scale of public sector funding, which if you go back to the mid-1990s actually was at a much more smaller scale, but there was a peak that went up through the early 2000s. That the nature of that funding is also changing. Many of you know that. It's commissioning, not grant funding. So there's quite a profound realignment. One might argue that it's interesting to say what's the norm here. Was the norm actually pre sort of the mid-1990s, or was the norm the last 20 years? Difficult to say. But there is a readjustment going on around the funding of the charitable sector. And there's also, as exemplified by those numbers, growth in what we might call the mega charities, the super charities, as NCVO calls them, and growth in the kind of profit with purpose world. Another area that I think really impacts on the charitable sector, and actually we've been slow to catch up on, is digital and data. And I think there's quite a sort of skills gap from there. And this just reflects the changes in life overall. I've got a lovely quote from Eric Schmidt, who, as many of you will know, is one of the founders of Google, which is that from the dawn of civilization up to 2003, and this is probably out of date by now, there were 5 billion gigabytes of information created. We now create that quantity of information, of data, every day. And you'll have seen from Valery's presentation how vital that data can be in actually enabling us to problem solve. But we also then have to think about, how do we use that data? How does that data then relate? And how is it made helpful for those who are operating at a community level in changing things? There's another lovely quote, and I'm afraid I don't know where I found this one, which says, "The best experts have dirty feet." And I think that's really lovely, because it says something about experts and it says something about practitioners, and it says something about how you need both to come together. So we're living in a lot of change. Your own sector is clearly an ecology that is not just about the charitable sector. There's clearly a lot of people here from the public sector. Local authorities clearly play a role in all of this. Commissioning is clearly a key part too. But at the heart, I think, of what all of you are trying to do is a common mission: HIV prevention. And that notion of mission, I think, is really important to how we think about how we can be effective. I use another model quite frequently, which I call the 3 M's. It's mission, money, and models. I first came across it when I was part of a working group in the cultural sector in the early 2000s, where there was a concern that a lot of cultural organisations had become preoccupied with money. I'm sure they're not alone in that. And that in so doing, they had developed models of operating and models of working that were focused on acquiring money, funding, rather than achieving mission. And I've always thought that actually that is a really powerful way of thinking about What are we building and how are we building it and to what end and for what purpose? And it focuses you in on that point of mission. So we've talked to some of the people that we fund and asked them about what they think is important in terms of how we take the voluntary and community sector forward, how they take it forward and how we can support them. And we've had some very clear messages, very clear message about the models. Start with people's skills, their relationships and their knowledge. Start with practitioners and start with being people-led. Empower people who have lived experience. Because generally speaking, they have the answers. It's just that, and I'll come back to this, we're not very good at listening all the time. You've actually been brilliant at listening this morning, which is why I'm on a canter. Support organisations to focus on their mission. Put mission at the heart. As a funder, don't make them focus on the money necessarily. Help them focus on the mission. Be more digitally enabled and data-driven, but be more human and be more focused on relationships and people. And then finally, and I'm going to talk about this a little bit more, one size fits all as an approach doesn't work. Takes us back to ecology. So in thinking about generous leadership, as Ian has suggested, I think you start with the context. You start with the ecology. We all, I think, understand the notion of biodiversity and ecology in the natural world. We may not, as a species, be terribly good at addressing our own impact upon it, but I think we do understand the relationship between nitrogen in soil and our ability to to maintain the plant and animal kingdom. We do, I think, understand the relationship between every species, every plant and every animal. Charles Darwin had a wonderful quote on earthworms. It may be doubted whether there are many other animals which have played so important a part in the history of the world as these lowly creatures. I think that's so great, that the notion that actually it's the earthworm in some ways that has held us all together and is absolutely vital to what we do. So when we're thinking about generous leadership, we need to be thinking about, well, what is our role, what is my role, what is my organisation's role in this ecology in which I exist? What do I bring to it? What can I add to it? And when do I actually need to get out of the way and let someone else do it because they can do it better? Or when can I support them to do that? We sometimes are so enthusiastic and so committed and so passionate that actually we want to be at the table all the time. Sometimes it's better to just make yourself a bit invisible from time to time. I started thinking about this when I moved really from having spent a lot of my career in the cultural sector and into the charitable sector. And I was struck in the cultural sector that when I started working, particularly in national museums, which would have been in the early 1990s, the national museums, they're great institutions. And they're sort of the envy of the world. We should be amazingly proud of them in this country. But their view at that point in time was rather that if they worked with a regional museum, it would be by lending the museum one of their C-list works of art, for which the regional museum would have to pay and would have to come to the very high standards that the National Museum would demand of them around display and conservation of the objects. Over the period in which I worked in the cultural sector, national museums underwent a profound re-evaluation of what their role as a national institution was and actually how their ultimate success to preserve objects and to display them and to educate actually was interdependent with whether or not those smaller regional museums or independent museums could also flourish. And so what happened was that national museums and regional museums started co-producing exhibitions. Works of art would go from a regional museum to a national museum. Part of the British Museum's Egyptian collection is now on permanent display in Birmingham. National museums run development programs for conservators and for curators for across the field. The same thing happened in the performing arts. The National Theatre realised that actually it could co-produce with small independent producers. It could make its box office available as a platform for some of those smaller companies to sell tickets. What's to lose? It's a real win-win for everybody. This doesn't just happen in the cultural sector. I think the notions of collective impact, which some of you may be familiar with, and place-based funding, where you bring people together to work collectively on a problem, you provide an infrastructure support for them that might do the sort of data gathering and might do the project management, and then you identify very clearly what are the different roles. And some of our funding programs in England around multiple and complex needs, or A Better Start, which looks at the life chances of those born into the most disadvantaged circumstances, are trying to operate in that sort of generous leadership mode. So what are the sort of characteristics? Well, firstly, I think it's a bit of a way of being. It's a state of mind. It's an understanding of how you are and how you think and how you relate. I think it is absolutely about listening. I remember someone saying to me that listening is the single most undervalued leadership and management skill. And I went away and thought about it, and I thought, yeah, that's right. I did an MBA. No one taught me how to listen, but actually it's so valuable. We support a program in Northern Ireland called Amplify, which works across a number of different communities. And when they wrote up their program, they said, we trod carefully and listened well. I think that's such a beautiful way of thinking about how you engage in communities and with people. Generous leadership is about context. It's absolutely about being mission-driven, and it comes in many shapes and sizes. And I thought I'd just share, before I finish, some examples of that that I've come across. And they're all different. So the first one I want to talk about is a wonderful woman called Helen Jones, who runs the Leeds Gypsy and Traveller Exchange. So Helen kind of exemplifies generous leadership characteristics. She sits on the APPG for Gypsy Roma travellers. She collaborates and influences right across her sector. She has worked with us frequently, helping us think about our funding in this field, because again, we're not an expert, even though, and I'm slightly embarrassed to say this, we've been very bad at funding her organisation. She's been very generous about that. That's the art of openness, the art of exiting. MAC UK, some of you may know, works with young people in North London primarily, on the streets, helping to address mental health issues. It was set up by Dr. Charlie Howard in 2008, with the express purpose that it should close itself down within 10 years. And what it is now doing, the art of exiting, is it is codifying its learning and its intellectual property that it can then share and make that available for organisations that might come after it. All its services are led by young people alongside mental health workers, and they're very much street-based. And the work that they're doing to codify will enable them to for that approach and that knowledge and that learning to be shared amongst all sorts of other charities, but also all sorts of other services. And it's led to, for example, the Home Office consulting with young people as they make some policy choices. The art of support, Catch-22, very large service deliverer, actually has set up a fellowship for innovative individuals in the social sector who need some space to reflect. In fact, Charlie Howard was one of the first ones to receive a fellowship, and basically Catch-22 paid for her to, I think, have a year or 18 months without agenda, a bit like the MacArthur fellowships, I think, in the US, to think about and to reflect on what she was doing and how she could take that forward. They also have stepped in to support organisations that have run into difficulties and taken them under their wing as part of their overall organisation. So most notably and most recently, Community Links in East London, which is, many of you will know it, it's a phenomenally successful organisation, but actually became financially quite vulnerable. It has merged into Catch-22, but will carry on with its local, it's embedded in the local, but with that larger, if you like, balance sheet and management support from Catch-22. And I'm going to finish with Terrence Higgins, The Art of Walking the Talk. So it's been great working with Ian on generous leadership and hearing about actually Terrence Higgins' strategy, which seems to me absolutely about working in partnership, recognising that you can't achieve your ambitions alone, that you have to understand what is your particular place. How do you need to then change as an organisation? Rather than necessarily having the Catch-22 model where you might acquire organisations, how do you actually work with others and add to them so that they're strengthened within that relationship? How do you use your position as a high-profile organisation to enable others' voices to be heard that may not be your own, so you become a platform? And it seems to me those are some of the sorts of qualities that generous leadership exemplifies. So in a nutshell, it's about your place in the universe. It's about being mission-driven. It's actually about contribution and not attribution. That's very counter-fashionable. But actually, isn't it so much more rewarding to think about what have I brought to this rather than what can I claim as mine from it? It's about ecology, it's about diversity, and it is about a generosity of spirit. But actually, I'm going to end with a quote from someone who sums it up much better than I. It's a John Donne's sonnet, which many of you will be very familiar with. If I were very mischievous, I would carry... I'm going to give you two couplets. If I were very mischievous, I'd do the next two. But because we're in Purda, I'm not going to do that. So I'll leave you to go and find out what the other two lines are. But I think this exemplifies generous leadership. No man is an island entire of itself. Each is a piece of the continent, a part of the main. Thank you very much.
Dawn, thank you very much for that really interesting contribution and for inspiring us as we go off to coffee. And I'm sure that if Dawn's around over the coffee break, and particularly if you're from a voluntary and community organisation and want to know how the big lottery might be in a position to support you, do grab her. But thank you very much. We come back at 20 past for the next session. Can you thank all of our speakers?